Today we're going to talk about some couple of neurological issues that you like to ask you, confuse you because they look similar and they're very intimidating. Myasthenia gravis, um, ALS, GBS, and multiple sclerosis. I'll try to make them easy for you because they can put them in the SATA question and you have to distinguish between which one it is. So let's get to it and I hope you get something out of it. So Myasthenia gravis. This is an autoimmune disease, and it usually involve your body making some antibodies against acetylcholine receptors. So you have these receptors on muscles that are involved with the movement, and so when you have these receptors not functioning the way they're supposed to, and then you have weakness. I'm going to explain to you what usually happens. So normally, this is in a normal situation. You have the nerve, and then this is the neuromuscular junction. And then you have myelins on the nerves. These are needed to help action potential or impulses or information to move faster. And then you have the muscle sitting here like that. And the muscle needs information from the neurons. So these neurons have neurotransmitters in them. And the neurotransmitters can be acetylcholine. So when you get to the information, we'll skip this myelin and you get to the neurotransmitter, to the synaptic cleft. This is synaptic cleft, and it's the same as the neuromuscular junction where the neuron and muscle has to communicate. Of course, they are not completely attached. These neurotransmitters need to, within the vesicles need to come out. So the vesicles empty out their neurotransmitters into the synaptic cleft, which is acetylcholine. And then on the muscle, you have these receptors that need to take the acetylcholine back. So this is the muscle. Okay. On the muscle, you have receptors. Of acetylcholine. So in normal sense, when the neurotransmitter is released, it binds to acetylcholine receptors. So these are acetylcholine receptors, ACH. That's the how to abbreviate it. And then when they bind to the receptors, they causes influx of sodium. And that's how the information, that's the impulse, the action potential is generated and the muscle begin to contract. So this is the easy, quick and dirty way of understanding what is happening. And nerves send its information through neurotransmitters, emptied into the synaptic cleft, bind to acetylcholine receptors. Usually acetylcholine as a neurotransmitter bind to the acetylcholine receptors on the muscle, causes the muscle to contract. And that is the normal way of functioning. Unfortunately, there is this, what we call antibodies, which involve with the myasthenia gravis. Your body makes unknown neurotransmitter, another antibody. So maybe, let me use another color, blue. These antibodies, they compete with the acetylcholine. Okay, they're competing with it. So they bind to the acetylcholine receptors rather. And you have the acetylcholine sitting there. They don't have anywhere to bind. When they bind to the receptor, the muscle doesn't contract. They are what we call competitive inhibitors. The muscles can contract. The acetylcholine is still floating. And so all the muscles don't function well. So this is the mechanism of the myasthenia gravis. And if you understand this, pathophysiology, treatment, education, management, everything is all connected. So you'll be able to answer any questions related. You have to come back to the pathophysiology of the disease. So what happened? Based on what you know now, okay, the muscles that are usually affected in myasthenia gravis, the key ones that they usually like to patient present are the muscles of the eyes. Okay, so and then swallowing muscles. So muscles that are involved in swallowing. These are the two key muscles. Based on this, okay, based on this, you can figure out what the patient is going to present with. So presentation, which in your exams is signs and symptoms, which they can say what is expected. A nurse is evaluating a patient with myasthenia gravis. What does she expect to see? Well, these are the two muscles that are really affected, your eye muscle and swallowing problem. So, well, I'm going to have this muscle problem then. I'll go to your eyes. What will happen in your eyes if your eyes doesn't work? Well, ptosis. You can have ptosis. You feel like it's coming up. And then what? You have double vision, diplopia. So that's what happened to them, right? And then the swallowing muscle, what is going to be? Well, they have swallowing problem. If they have swallowing problem, well, they will have some dysphagia, okay? And most of the muscles that are involved in swallowing can go into the upper airway, so they may have difficulty breathing. It's a sign muscle, all the muscle weakness. And they get weak also. Guess what? The muscles that control your bowel respond to acetylcholine. And if there is no acetylcholine receptors that will bind to acetylcholine because it's being bound by the autoimmune chemicals in the system, well, they have bladder issue. The bladder and the bowel issue. So they have bowel incontinence. So they cannot hold it. Bowel incontinence. And then they have a bladder also issue. This is a big problem. You see how I'm able, out of two information, I can give you a certain question and you have to figure out yourself. One key issue with this disease is the muscles are good. They are stronger during the day. So in AM, they are strong because they still can bind to a certain and the receptors can bind to certain acetylcholine receptors, even though there's competitive inhibition. So they are stronger in the morning, but later in the night, later during the day, as the day progresses, they get weaker. So this is your information, and then you have to apply it to patient teaching, patient treatment, patient management. So what do you do with this patient? Well, if I know that there are muscles, so this is what they will ask you, teaching, education. So what will you tell the patient? If your muscles are weak during the morning, no, they are stronger during the morning and weak during the evening. Well, take your medication in the morning and take it in AM meds because your muscle, you can swallow better. Let them swallow their medication in the morning so that when they get weaker during the day, night, they can swallow, they can aspirate. If their muscles are stronger, yeah, you give them activities that they need to do in AM. So if they have physical therapy, they be admitted, their physical therapy in the morning, scheduled for the day, let them change it to AM, physical therapy in the morning. If their muscle are weak as they chew and swallow, well, let them have small meal, okay, at a time. But it has to be frequent, so more often, but small. And then because of that, you get to increase their calorie. So small meal, increase frequency, and have more calorie in it. And what should be your number one for this patient with the swallowing issue? B sharp, airway. So airway. Prevent what? Aspiration of this patient. Because if they have swallowing problem, they may aspirate. So you need to prevent it. Prevent it as much as possible. And if they get weak during the day, throughout the day, as the morning progresses, take them to take rest. Take frequent rest. Because you can get tired if you try to overexert yourself. Frequent rest. So you see, we've used the pathophysiology to answer all these questions. And if you want to prevent aspiration, this one, what do you tell them when they're eating? What do you think? Well, your head, flex your head forward, head flexed forward, so that you don't aspirate. And what kind of food will you give them? Clear liquid is not good for them. So something that is taking consistency to prevent aspiration. You see what I've done? This is all interrelated. That's how I want you to think when you're trying to study for your exams. Watch my video on how to study. You got to connect things together. If you know a patient who aspirate is a high risk of aspiration, then have a suction at bedside all time, okay? In case they aspirate, then you can suction them. You see, they are all the same thing. Well, somebody will say, what are the triggers? That's another teaching you can provide to this patient. Number one, I usually simplify it for me. Like I say, I'm a pathophysiology guy. So stress, decrease stress. Whatever is going to decrease stress, anything in the form of any name he has, and if the underlying problem is stress, is take it. So infection. They should prevent infection. Infection is a form of stress to the body. Therefore, what do you teach them? Well, get your vaccination. Don't skip it. Whenever there is a vaccination annually, please get it, because if you get pneumonia, you're dying. So you want to prevent infection as much as possible. Another thing that will cause stress is what? Emotion. So let them control their emotion. Any highs and lows of them emotion will put stress on them that can trigger the disease. Because of that, is to avoid extreme, okay? Avoid extreme temperatures, which is a stress on the body. So they can have like cold and warm. Too much, the temperature is too high, too low, it's not good for them. And sometimes it's because of medication. They forget to take their medication. So then they are not compliant with medication. So you teach them all these things. Okay. They have to avoid trigger. That's whenever they're going home, please avoid trigger of this disease. Otherwise, you're coming back. Now, pay attention. So, somebody coming with Myasthenia Gravis crisis. So, MG crisis. How would I know they are in crisis? What are they lacking? They're lacking acetylcholine to bind to the receptor. They have it, but you have a receptor which is being bounded by these autoimmune antibodies that is being produced. So they're competing for the same thing. Well, if I want my acetylcholine to win, I need to bring in more acetylcholine to help with that. So if I have two of this is more likely to bind. How can you improve the acetylcholine level? Well, there is if this is acetylcholine, usually when your body doesn't use it, there is an enzyme, acetylcholinesterase. This is an enzyme that will break down the acetylcholine because you don't want your body to be in a cholinergic crisis. Maybe that means a lot of acetylcholine floating around, not doing their job. So this enzyme will come and break it down. It destroys the rest of acetylcholine. And the body will make more if they need it. So the trick I can do is, well, I can block this enzyme to allow this acetylcholine to float around. That means I have more acetylcholine that will compete with the antibodies, which is produced by your body alone, that is fighting against the receptor, and therefore I have more acetylcholine to compete with the antibodies, and they will rather bind to the receptor. If this is the receptor, the acetylcholine is more likely to bind, and the individual will function better. Therefore, we have a medication that can bind to acetylcholinesterase. That's the enzyme. And that medication is phonium. And the test is called Tisserand test. If you see it in your exams or any Q bank, that's what it means. When they say patients are undergoing Tisserand test, basically TENSILON, Tisserand test, you giving them androphonium to block acetylcholinesterase to increase level of acetylcholine. Well, now I have more acetylcholine. What do you think is going to happen to them? Their symptoms may improve. So improve symptoms. So symptoms will improve. So if they have double vision, it get better. Bladder problem, it get better. If you have swallow problem, it get better. And this is where you can determine if they are in crisis. And so it's good treatment, and you make a diagnosis that, okay, I've treated it. Therefore, now I know that they are in Myasthenia Gravis crisis. Well, I can do the same thing. I can have another medication as acetylcholinesterase. I can have a medication that can block this better. They can last longer. And they are called stigmin. They are stigmin. Their last name is stigmin. Stigmin. They bind to the acetylcholinesterase. They increase the level of acetylcholine and the individual function. So that's the medication they give them. That's the last name. So you will see in your exams, there will be neostigmin, or it can be physostigmin. Don't matter the first name, watch the last name. They all have stigmin. No matter which one they give you, there's a bunch of them. So far as he has a stigmin, I'm picking that for myasthenia gravis, depending on the question. So these medication can block acetylcholinesterase longer. The androphonium usually lasts for 5 minutes, so it doesn't last long. But this can block it for a long time, and you have more acetylcholine, and the individual can get better. because it binds to the receptors. So that's the treatment. You give them neostigmine or physiostigmine to help with the function of it. The other medication you can use is steroid because it's autoimmune. Every autoimmune disease needs some steroid. But nothing is free. Guess what? If you give them neostigmine, okay, you have high level of acetylcholine. Sometimes you overshoot, okay, overshoot. You go overboard. You're giving too much. Your body, they produce too much acetylcholine, and they have more acetylcholine in the system, which is not bad. And if I'm an examiner, I can ask you a question about it. This is called cholinergic crisis. Initially, they are in Myasthenia Gravis crisis. Now they are in cholinergic crisis. That means they have two cholinergic crises. They have too much acetylcholine in the system. And what happened? This is what they like asking. If you have too much acetylcholine in your system, what does acetylcholine do? Well, it stimulates the parasympathetic nervous system. Well, increase salivation. You salivate more, right? And what happened? You pee more. I know you know this, but I just want to put in a SATA question and see. You pee more. Well, you have diarrhea or cramping, right? If you initially you have double vision because you have myasthenia gravis, you don't have acetylcholine. If you have too much of it, well, you have pupillary constriction. Now it constricts. It's so small. It's tighter. It's a problem. If too much acetylcholine going on in the parasympathetic nervous system, your heart rate come down. And then your blood pressure come down. You see what I've done? I've turned the whole thing around. And that's when you study, that's what you should do. And that will make sense when you see answer choice. That's the why. Why you start asking yourself, whoa, this everything makes sense. I mean, I don't even have to memorize this. Then it will ask you, well, how do you treat these cholinergic states that you created mistake by overshooting with too much neostigmine? I like to teach pharmacology when I teach. So you see, this is a pharmacology. You're going backward. Now, how can I antagonize neostigmine? I cannot take it away, but I can take the effect of neostigmine, which is high acetylcholine, that will put me in cholinergic state. The antidote is atropine. So you give them atropine, and that will take care of all the symptoms. That will stop it. So that's what you do. It's a antidote for that. Then somebody will ask, well, they can also ask you, oh, how would I know they are in myasthenia gravis crisis or cholinergic crisis? You have to do that. When they come in, you have to distinguish between these two. Hey, somebody with myasthenia gravis come in, is weak, is this and that. Do I know if he's in myasthenia gravis or cholinergic crisis? This is what they will be start asking next year in the next generation questions, that because you got to make differential diagnosis, but you have to use your pathophysiology to think about it. In one of them, myasthenia gravis, where crisis, the acetylcholine is not binding, so they have decreased amount, binding to the receptor. Cholinergic, where there's too much of it. It's not that it's decreased, it's not binding to the receptor in myasthenia gravis. So if you increase the level, it will improve. So I would say, well, I need to, if I give them androphonium, if I do the Tessalin test, which is what? We talk about it. I'm giving an enzyme that temporarily block the acetylcholinesterase that increase my acetylcholine a little bit, then I will know what will happen. What do you think? Who is going to get better? Myasthenia gravis patient or cholinergic patient, crisis patient? Well, it's going to be myasthenia gravis crisis patient because they need more acetylcholine. Cholinergic crisis patient doesn't need it. So if you do the Tessalin test, myasthenia gravis patient will get better, but cholinergic crisis patient will get weak. Its symptoms will get worse and worse and worse. And this is all you should expect. You should keep on asking yourself, this is the way you should go in circle. That's how they're going to ask you. So that's everything about myasthenia gravis. And then if you understand this, there's no question that will beat you. So the next one is ALS. Okay, this is named after a gentleman. The same thing. If they write it like that, Lou Gehrig's disease, named after this gentleman. It's a bad one. It's one of the bad diseases of the model. We don't know what causes it. There's no cure for it. It's a progressive disease, so it keep on going on. Progressive disease. And what does it do? You know, the neuron, I show you the same thing. Motor neurons are affected. Where is these motor neurons specifically are affected in? In the brainstem and the spinal cord. So, and you can think out of this, you can guess, okay, if the brainstem and the spinal cord motor neuron is affected, well, what kind of symptoms will they have? Brainstem is usually what control your breathing and swallowing. And the spinal cord, if you look at the cranial nerve, that's where most of the cranial nerve 9 and 10, they near the brainstem. So, and it also the brainstem also control breathing, and the spinal cord usually involved with your movement. And you can see just by that, I know what the patient is supposed to look like. They will have breathing problem, they will have movement problem. All muscles are affected. All muscles. No muscle is left behind. Okay. And the muscle become weak because it cannot function. Right? It cannot function at all. I mean, it's a sclerosis of the neurons in the progressive and usually the brainstem and the spinal cord. So all the muscle become weak. And if they're weak, they become atrophic. If the muscle weak and cannot function, they usually become spastic. So they get stiff and spastic, or they twitch. Fasciculation. I'm just going by what I know is happening, breathing, movement issue, and I'm doing deduction. That's what you should do in your head. If they have breathing problem, and then I should worry about aspiration, then airway issue. In the muscles, the cranial nerves that are involved, or the portion of the brainstem is also involved in swallowing. So they have swallowing and then respiratory issue. So those are the things, and these are the priority 1 and 2, airway and swallowing problem. And this is what killed them. They died from respiratory failure. Okay, they will have difficulty speaking because of the swallowing. There's something they call dysarthria. Okay, and then chewing will be a problem too. It's all related. So, what is your teaching? What do you tell this patient? Well, if you are the nurse, intervention, somebody admitted with ALS, What should you be doing for them? Well, manage their airway, okay, and prevent aspiration. Because the airway is very important, sometimes this patient, they already have tracheostomy as the disease progresses. And then to prevent aspiration, they will have a gastrostomy tube, so G tube, gastrostomy tube for feeding. You cannot prevent this, so supportive care. The family need help. And this usually is very important that because they need supportive care, all the problem they have to undergo, feeding, respiratory, spastic, and movement, they can ask you where they need physical therapy. What else do you think they will need? Occupational therapy for the spastic. They will need speech therapy to help with the swallowing. And of course, they will need home care to assist the family cope with the situation. And then this is very important. I think people don't talk about it, but I think you should encourage them to have an advanced directive because this is not curable. I mean, I don't. They sometimes they can put this in the SATA question. They need advanced directives because this is a progressive disease. It's not going to get better. It's going to get worse progressively. They will have being fed. They will have bladder problem. They have incontinence. They will have tracheostomy. They will be bedridden, and so they have to make decision whilst they can. That I don't want this. I don't want this. I don't want this. I don't want the trach. I don't want the feeding tube. When I'm ready to go, let me go. So, and this is the same thing. I'm digressing a little bit. Patient with Alzheimer's disease and the dementia, because these are all progressive disease. We should be thinking about this when you, as a nurse, or they ask you a question or those things in the SATA. I will be taking it. Advanced directives in Alzheimer's dementia patient, they should be making that decision because they get to the point you can't talk to them anymore. So early decision as much as possible. There is no cure for this. Okay, there's no cure, and they usually it will be dead in 5 years. So they can die in 5 years from the start of the diagnosis. Luckily, there's a medication that I think they can ask you. Okay. And this is the name of the medication. Riluzole. They like asking that. Okay. And the trick when they ask you this, be careful. Don't fall for it. It does not prevent the disease. Prevention is known. It does not resolve the disease. No. And it does not cure it. None of this. No prevention, resolution, or cure. All it does is it slow down the progression. Slow down progression of the disease. How? We think it binds to glutamate, which is the chemical that binds to the neurons and destroy the neurons. So riluzole is an antagonist to glutamate and give you some time for the progression. So assuming you're going to die 5 years, well, probably it can get you to like 6 months additional. So just 6 months, 6 months additional time. And so it just slows down the progression of the disease. It does not prevent it. It does not cure it. So that's the key you should pay attention to. So that is how for ALS. The same friend, same language, they look the same. It's also an autoimmune disease. They all look the same, but there's key difference. This is an acute problem though, and you occur after some URI symptoms, upper respiratory infection or GI symptoms. Nobody know what happened. The same issue with demyelination. So let me explain the demyelination here. So this is the nerve, okay? And this is the synapse. And you have myelin here. Myelin are fat on the neurons, and they occupy the neurons. And this is very genius design. Usually when message is coming, instead of running around the neuron, it takes a long time. You get here, you say, oh, there's no space, I skip. I got here, no space, I skip. You see how fast I move, skip, and get to the head of the neuron. In a demyelinated state, this is what you have. The myelin is there, but it's just like tiny one. There's big space, everything is gone. And so messages, they have time. Oh, I go here, I go here. I don't have to jump too much. Slowly. Then I take my time, slowly. You see how long it takes a long time for neuron to get here. And so messages, information, and function is slowed down. Everything is slowed down. Therefore, what kind of symptoms do you expect to find? Before that, let me explain two things so that you can use that. One key, even though these diseases look the same, they all have two words that you should remember. This is what we call ascending paralysis. What it means is your muscles stop working from your foot upward. So your foot doesn't work, muscles start working, then your legs, maybe your knee, before your knee break down, then your hips, your bladder, your bowel, then your airway, your swallowing. So it starts from, it's like something ascending from the lower extremities up. So they have symptoms start from the lower portion of the body and come. So they have lower extremities weakness before the upper extremities, but it's a progressive diseases and paralysis. So at the end, the last thing that are affected is the respiratory muscles and the swallowing muscles. It's the same, look the same thing as the ALS. And based on that, you expect them to have what? Signs and symptoms, the same thing. Okay, they're going to have bladder problem. Okay, they're going to have bowel problem, right? They're going to have weakness. They're going to be paralyzed from the lower extremities down. They're going to have swallowing problem. And then finally, what? Respiratory problem. You see, everything is connected. Back, we're going back. So that's the way they work. Luckily, this disease is better. It can resolve in 2 years, unlike the other ones that doesn't go away. The ALS, that is forever, you die from it. This one, in 2 years, you should be fine. Okay, the other thing to these people, their reflexes will be down. Okay, so in 2 years, the disease will go away. So you got to tell them, and so they will get better in 2 years' time. That's how long it can last. So, what is the treatment? It's an autoimmune disease. So you can give them steroids or immunosuppression. You can choose anything you want. The other thing they do is with autoimmune disease, they can take the blood out and filter it to remove the antibodies. And that is this fancy word, plasmapheresis. Basically, they remove the plasma and they filter it from all the antibodies and put it back. So that's plasmapheresis. So that's what they do. If this patient is admitted in the hospital as the nurse, what will be your intervention based on the pathophysiology? What is your number one? Your priority, I told you, is airway. So watch for aspiration, watch for swallowing problem, and respiratory issue. Of course, they're going to have bladder issue, they're going to have bowel issue, they're going to have weakness of their leg, they're going to have paralysis. But all this, what? This is expected. I don't care about it. If they ask you a question for priority intervention, yes, bladder, bowel, weakness, I don't care. Or any patient with, who do you see first? A GBS, a GBS patient came in with the bladder incontinence. No, it's not a priority patient. GBS patient with the bowel incontinence. No. Weakness. No. Paralysis of the leg. No. But if they say he has a swallowing problem, yes, you better pick that one. He has airway problem, it's better pick that one. He's drooling, he can't swallow, you better pick it. And that is B sharp. Airway, which is drooling, grunting, stridor, restless, is all airway. You better pick it. Bowel, bladder, weakness, paralysis is expected finding. It's not a priority. Airway is a priority that you need to choose. And finally, for that patient, because of all the things they need, they all need these ancillary staff to help with that. So they need a physical therapy. They need occupational therapy. They need what? Respiratory therapy. And finally, they need speech therapy to help with the swallowing. And the last one, same thing. I'll be saying the same thing. So for this disease is also, all the four of them affect nerve function, neurons in the brain, and they function and they affect muscle function. This is a chronic problem. Multiple sclerosis is a chronic problem, and it's progressive also. It never stops getting better. It keep on going on and going on and going. You can solve it. And the same thing is what? Autoimmune. Your body basically, for what reason, it makes something up and then cause this problem. The same thing I said is a demyelination problem. So multiple sclerosis patient, they have this tiny man on this thing in the patches. If you do a brain MRI, you will see it. The demyelination in the brain and the spinal cord. So it's a demyelination. Myelin. That means there's no myelin, no fat bubbles on the neurons that allow messages to go faster. So messages will be transmitted in the slow fashion. The problem with this is they have relapse and remission, and that is the killer. They do better, then they flare. Do better, and they flare. Better flare, and they keep on going back and forth, back and forth. We're talking about muscle and neuronal problem, and the same thing, signs and symptoms you should expect in the SATA. What is the next expected? Which one you should intervene? Well, they get tired, fatigue, right? Your eyes will be in trouble. So vision problem, they have double vision, diplopia, and they get this, what we call nystagmus. Nystagmus. So basically the eyes keep on moving faster back and forth. And when it does that, they have 4 risks. So you should make sure if they give you that, a patient with nystagmus, they can fall. So protect them from falling. They have slurred speech. The same thing we've been talking about is because of the swallowing muscle involved in swallowing. Because their muscle will not be working well, spasticity. It becomes spastic. They become weak. The muscle also become weak. And for all of them, you know what they have? Bladder and bowel. Bowel symptoms. All of this, okay? I'm not worried about fatigue. I'm not worried about vision. I'm not worried about spastic. I'm not worried about weakness, bladder, and bowel. If they ask me for priority, I'm worrying about speech, swallowing issue. That is respiratory, airway issue. That's the B sharp. That's my B sharp. So I saw this patient as a nurse, which is a priority intervention. Boom. Slurred speech and swallowing is my problem. So how do you treat this patient? It's based on what you know they have. You can solve it, you can prevent it, but you can treat their symptoms, right? If they have spastic, what medication do you use for spasticity? So spastic, relax them. So use baclofen. Just relax them. You can use diazepam, it's fine. Or dantrolene, anything that can relax them is fine. But baclofen is what usually they like asking. But diazepam and benzos or dantrolene can use that with that. And this, I'll do a lecture on urinary symptoms. So they have incontinence, okay? Why do they have incontinence? Their bladder is what? They have overactive bladder. So let me spend some time there. This is very important. Some students get confused. So they have overactive bladder. I'll do some pharmacology right now. Let me just get there. I think it's very important. So this is your bladder. And then you have your urines there. Urine, okay? On the bladder, there is an acetylcholine receptor. So this is acetylcholine receptor. If you acetylcholine, the rest is bind to this. Acetylcholine bind to the receptor and the bladder. What it causes the bladder is to void. So if you have acetylcholine, your bladder will do what? Void. Is involved in voiding. So emptying your bladder. Okay? So if you don't have, if you block this acetylcholine, if you block it, so something block this, block like that, there's no acetylcholine, you go into retention. So this is the question. If you see most of the urinary symptoms, medication, or pharmacology is get confused. You don't know which one you need to choose. This is the easy way to remember it. The bladder work with acetylcholine. So if you give me acetylcholine, I will contract and void. If there's no acetylcholine or something block it, I will go into retention. Medication that causes the bladder to contract because they look like acetylcholines. They have last name as Chole. Last name Chole. C-H-O-L-E. Example is betanacol. So you see betanacol, they have this last name, betanacol. If you see a medication with last name betanacol at the last name, is going to cause the bladder to contract. Medication that causes the bladder to slow down, okay? It causes the bladder to slow down. They have something we call butinin. That's how I remember it. I'm teaching you how I remember it. So butinin. So oxy butane. There's few of them that doesn't follow that pattern, but what I've seen is like in test questions, in the way I've seen in test questions, usually they look like that. They will give you something that everybody can recognize that is general. Of course, you have to know the few ones that deviate, but those with the core causes the bladder to contract. Those with butane causes the bladder not to contract. So butenes, if you give somebody butane, priority, I'm giving you another question. Priority evaluation is to check their urine output because they will go into retention. Somebody with core, priority intervention is check their urine output. Urine output will increase and they get dehydrated, or they'll become incontinence because they're peeing too much. So butenes are for slow down. So these patients, multiple sclerosis patients, they have overactive bladder, you give them butenes. Other symptoms that is classic for multiple sclerosis is because of all the symptoms they have to undergo through, they have depression. They go into depression. And so they will need a SSR. So this is a summary. You see, and finally, in order to finish, I'll add one more thing. Education for multiple sclerosis patient is what? Prevent triggers, okay? Triggers that causes them to relapse. You want to prevent it because it's going to continue all the time. And self-catheterization, you got to teach them how to do that because they will be incontinent, so they need to do that to prevent overactive bladder. And so that is a summary of all the things, these four problems. I know they look the same, but I try to focus on one thing that each of them have that is specific. So, I like to do some few questions to just see what we learned from it today. So, best way to answer NCLEX question, read the last statement. Which observation need priority intervention? So my keyword, priority, and what do I need? Intervention. I need to intervene. So I write my keywords there. Priority, intervention, observation. A client with what? GBS. So what do I expect the GBS patient to have? That not just the expected, but a B-sharp one. Something is a B-sharp issue, not just expected. So there are no certain things I need to see, but there's one when I see, I'm worried that, and I have to be sharp about. The GBS people, well, they have urinary incontinence. I don't care about it. They have constipation. I don't care about it. Orthostatic hypotension. I don't care about it. Unable to control their saliva. That's another way of telling you that what? You have airway issue. If you can't control your saliva, well, aspiration. And this is when you write B sharp, it's airway. It's an airway issue. So this is what the right answer. Another question. A client, so start a question, you read the last one. Which teaching, so I'm worried about teaching, at discharge need intervention? Okay, so you need intervention. Somebody says something that is not appropriate. A client was ready for education after Myasthenia Gravis flare-up. So he has Myasthenia Gravis flare-up. What would he say that need intervention? I will take my medication in the afternoon. We talk about it. The good in the morning and weak in the afternoon. They can swallow well in the afternoon. If they take medication in the afternoon, they're already weak. They can aspirate. So this need intervention. So this is what I need to choose. I will take frequent breaks. Yes, because they get tired. So I don't need to worry about it. I will get my annual flu vaccine. Yes, go get it. Otherwise, you get sick. I will eat regular food. You want them to have thickened, so semi-solid, I think is good. So this is wrong. I will have abdominal cramps after neostigmine. Well, we talk about it. When you give somebody neostigmine, you increase the acetylcholine. If you overshoot, or even more acetylcholine will cause diarrhea and muscle cramps. So this is good. So that's how you do that. Straightforward, using pathophysiology to answer this. Another question. Which of the following finding is expected during NCLEX assessment? For what? Patient who is diagnosed with GBS. So I'm looking for all the symptoms. Then you ask yourself, what is GBS? I know it's a demyelination problem. And then what is the other keyword? Well, it's ascending paralysis. These are the one I want you to pay attention. So all of them has one word that apply to them. GBS is an ascending paralysis. The rest is the same. Orthostatic hypotension is suspected. Bladder issue is expected. Ptosis, you know, is Myasthenia Gravis. No, so wrong. Weakness during the night. No, they're weak. If they're weak throughout the day. I mean, it doesn't matter what day. This is specific for Myasthenia Gravis. They get tired. Muscle weakness. Yes. Reading problem. Yes. Prescription for Riluzole. What do you think this medication is used for ALS? Just put all these together, these four. It's easy to confuse, but pay attention to one specific things about each of them. And when you use the pathophysiology, you'll be able to figure out what kind of symptoms they're going to have. There's one specific symptoms for each one of them. But the treatment they can ask you, especially Myasthenia Gravis, and then cholinergic crisis, they can ask you, how do you test for it? What medication you use? ALS, what do you use for the medication, and whether it's for cure or decrease the progression, and the priority, pay attention to priority intervention. Some of the expected finding that bladder, bowel, weakness, paralysis, they are not important. Who do you see first? Don't care about them. All you care about, if they give you ALS, multiple sclerosis, myasthenia gravis, and GBS, all you care about is a swallowing and airway problem, is the one. If they give that as a 4 patient, and would you say, if they said they have swallowing, airway, speech problem, that's the people you worry about. That's the people you see. Take care of yourself, and good luck, and keep charging as always.